Hello everyone. Today's topic is the theoretical introduction to the joints of a human skeleton. Unfortunately, the sources were only 90% matching, which leaves some room for interpretation and some contradictions between the sources. So if you're studying for your exams, go by what your professor says, and after that, sort the classification in a way that best suits your understanding. The theoretical introduction to the joints. First, we define what joints are. A joint is a construct that connects two or more bones with each other. You could also say that the two bones communicate or articulate with each other. Figuratively speaking, we could also say that we have a gap between two bones and that this gap is then filled with a substance, or more specifically, connective tissue. There are two ways to classify joints, which I will explain to you with the help of a table. Very roughly, we have joints without cavities and joints with cavities. The first classification is by structure, or more specifically, by the histologic tissue that primarily fills the gap between the bones. We have fibrous, cartilage, bony, and synovial joints. The fibrous joints are subdivided into sutures, fibrous tissue joints only between the different parts of a skull, gomphosis, fibrous tissue joints only between the teeth and bones, and syndesmosis, fibrous tissue joints between two ordinary bones. The cartilage joints are divided into synchondrosis, made of hyaline or primary cartilage, and symphysis, made of fibrocartilage or secondary cartilage. The bony joints are also called synostosis. The synovial joints can be subdivided by structure into simple, compound, and complex, and by function. The second classification of joints is made by function, by how mobile the joints are. In most cases, the joints without a cavity are immobile synarthrosis, and the joints with a cavity are free movable diarthrosis. Joints that are slightly movable are called amphiarthrosis, such as the symphysis, syndesmosis, and plain synovial joints. Now we will talk about the examples of each structural joint type, starting with the fibrous joints. As already mentioned, the sutures are only on the skull, and gomphosis are only between the teeth and the respective bones. The syndesmosis of a human body are syndesmosis radioulnaris, tibiofibularis intermedia, and tibiofibularis inferior. Next, we have the synchondrosis. In the adult body, they occur only between the bony and cartilage parts of the 12 ribs and between the first rib and the sternum. The symphysis of the human body are symphysis pubica, symphysis intervertebrale, and symphysis manubrio and xiphosternalis. And since they are all amphiarthrotic, they are slightly movable. Examples of synostosis are sutures, former fibrous joints that ossify when getting older, epiphysis of joints and hip bones, former hyaline cartilage joints that ossify when you become an adult, as well as os sacrum and os coccygeus. The subdivisions are ossified before birth. The synovial joints can be divided into 7 functional subtypes according to their shape. The number next to the subtypes indicate whether the movement of a subtype is mono, bi, or multiaxial. The G stands for gliding movements. So let's do a quick summary of the joint classification. The joints are roughly divided into joints without a cavity and joints with a cavity. Then, classified by structure, there are fibrous joints with the subtypes sutures, gomphosis, and syndesmosis, cartilage joints with the subtypes synchondrosis, made of hyaline cartilage, and symphysis, made of fibrocartilage, bony joints, which is a synonym for synostosis, and synovial joints, which can also be subdivided. When classified by function, there are synaphrosis, diaphrosis, and amphiarthrosis. Amphiarthrosis are the syndesmosis, symphysis, and plain synovial joints. Here you have a table of all joints in the human body from the head down, with the articular surfaces, stabilizing ligaments, types, shapes, and range of motion. In this second table, you can see from which sources I've got the information. You can find the two tables as a PDF document in the description. Microscopic structure of synovial joints. The main components of a synovial joint are, for one, the articular surfaces of the bones, which are lined with hyaline cartilage. Next, we have the synovial membrane of the joint capsule that attaches close to the articular surfaces, and the fibrous membrane that lies over the synovial membrane. The fibrous membrane doesn't just simply insert into the bone, it continues as the periosteum, a thin layer of connective tissue that surrounds the entire bone. The joint capsule limits the joint cavity and also produces the synovial fluid. Now, the side components. Joints have sometimes intra-articular support structures that are located within the joint cavity and are therefore in contact with the synovial fluid. They are usually made of fibrocartilage. There are three types of support structures: labrum, articular discs, and menisci. Note that articular discs of the synovial joints are not the same as the discs in the symphysis, such as the interpubic or intervertebral disc. Next, we have the ligaments that basically all synovial joints have. The ligaments can be capsular, intracapsular, and extracapsular. There are also most of the times muscles that pass over and move the joint. Lastly, we have three types of synovial-filled sacs. Recessus provide the residual spaces of joint capsule during movement. Bursa and tendon sheaths reduce the friction. The histologic components of a joint capsule are the outer membrana fibrosa, made of dense connective tissue, and the inner membrana synovialis, made of subintima and intima. The intima is only 1 to 4 cell lines wide and is composed of synoviocytes type A, which are a type of macrophages, and synoviocytes type B, which are the cells that produce the synovial fluid. The layer below the intima is the subintima, which contains various types of connective tissue, such as fat cells, intracapsular ligaments, and more, as well as sometimes blood vessels. The subintima is more shiftable, allowing the intima and the membrana fibrosa to move more independently from another as the joint moves. The two insufficient defined terms and other unclear points. There were two terms which made me struggle to understand the joint classification, so I would like to discuss these two terms in more detail. First, the syndesmosis. These are fibrous joints that connect two ordinary bones with each other, such as the membrana interossea antebrachii. The problem is that some sources include stabilizing ligaments as a syndesmosis too. This would make the knee joint, for example, consist of as many additional joints as it has ligaments, which would be 6 for each of the knees, not counting the intracapsular ligaments. However, since the ligaments are only secondary there to stabilize the main joint and are not the primary substance that connects the bones, they should in my opinion not be considered as a syndesmosis. Therefore, I would consider membrana atlantoaxiale anterior and posterior and the 6 ligaments of the spine, which in terminologica anatomica are considered to be fibrous joints, as stabilizing ligaments and not syndesmosis. The mentioned ligaments are also considered stabilizing ligaments in the Memorix Anatomie book and in kenhub. Next, in Terminologica Anatomica, the ligamentum transversum superior scapulae, coracoacromiale, sacrotuberale, and sacrospinale, as well as the membrana obturatoria, are considered to be syndesmosis too. I didn't consider them being syndesmosis because of didactic reasons. It looks cleaner if the only syndesmosis of a human body are on the distal part of the upper and lower limbs. But if you like it better or want to be more precise, feel free to include the mentioned ligaments as syndesmosis. The second insufficient defined term is amphiarthrosis. Some sources say that all fibrous joints are synarthrotic, all cartilage joints are amphiarthrotic, and all synovial joints are diarthrotic. However, more detailed sources like Terminologica Anatomica say otherwise. The biggest problem though are amphiarthrotic synovial joints. While the sacroiliac joint is broadly considered to be an amphiarthrotic synovial joint, I couldn't find any popular English source that would list each of the amphiarthrotic synovial joints. Only in the German version of kenhub did I find that the following joints are also considered to be amphiarthrosis. I realized that all of the named joints were plane joints, and since all plane joints are only slightly mobile, I considered all plane joints as amphiarthrotic, even though there was no source that explicitly said so. Other facts for which I could not find enough information or that I have changed for didactic reasons are listed here. Now that we have discussed the theoretical introduction, I will explain to you the next steps for learning the joints. We will draw all the human joints in 4 videos divided into the following regions: the region of the spine and thorax, the upper extremity, the lower extremity, and the knee. In the videos, I will name the joints and draw the stabilizing ligaments. The articular surfaces of the joints, the type, shape, and range of motion will be mentioned in writing. Also, most of the time I won't mention the joint capsule, since it basically is always attached close to the margin of the articular surfaces of a joint. Alright guys, that's it for the theoretical introduction of the joints. If you have any questions, let me know it in the comments. So, thanks for watching and see you next time.